Well, good evening, everybody, and welcome to our Meet the Experts patient webinar this evening. My name is Julia Priestley, and I'm one of the joint CEOs at the BTF. This event has been arranged as part of our current weight loss and well-being project, which many of you may be taking part in. If you are, then I really hope that you're enjoying the resources we're sharing with you each week and feel that you're really benefiting from taking part in a project like this, which is really tailored for the thyroid community and from which we hope to learn more about what will help you in the future. If you're not yet signed up for it, it's not too late to join. So please go to our website after the event, and we'll be delighted if you'd like to register for it. Our first webinar was an overview of weight management and thyroid disease. But tonight we'll be focusing more specifically on obesity and weight. There's a huge amount of discussion about obesity in the press, in public life generally. Today, if you're in the UK, you'll have heard and read the news stories about Wegovy, the new weight loss drug. But we hear very little about whether there are particular issues and considerations for people who are living with thyroid disease and are also obese. And if there are, what are they? And if so, should there be more dedicated support for the thyroid community? Well, to help us understand more about the questions, I'm delighted to introduce you to our three expert speakers who between them have years of experience of working with patients who would like to better manage their weight. First of all, Dr. Angelos Kyriakou is a consultant in endocrinology, and he's based currently in Limassol in Cyprus. And then Dr. Jonathan Hayes will follow him. He's a registered dietitian with many years of experience working with weight management services in NHS Lothian in Scotland. And finally, Dr. Jonathan Hazelhurst from the Institute of Metabolism and Systems Research, and also an academic clinical lecturer at the University of Birmingham, will be speaking. And both of our doctors have extensive research interest in the endocrine system and how it relates to the metabolism and weight. So in a moment, I'll hand you over to them. And while they're speaking, you'll be very welcome to put any of your questions into the Q&A chat box that you'll see at the bottom of your screen. And after their talks, we'll put those questions, pick the questions out and put them to our speakers to answer you. We've got a lot of people on the webinar tonight, so if we don't get round to answering your question, we'll try to follow them up after the event. And of course, you're welcome to contact us at any stage afterwards with a question. So without any more from me, I'll hand you over to Angelos, Dr. Angelos Kyriakou, who will start with the presentations.
I hope that you can see my screen. Can you hear me?
We can hear you, but can you share your screen? Can you share your PowerPoint?
I thought I've done it. Let me try again. Screen share.
That's it.
Okay.
That's it. And
let's make a start.
Can you click from the beginning?
Yes.
Perfect. Thank you.
So thank you for having me at this webinar. Let's start with a brief revision of thyroid physiology. So the thyroid is a small gland at the front of the neck, which produces thyroid hormones. These affect various functions in pretty much all tissues and organs. One of the functions they influence is energy production, energy consumption, and energy balance, processes known as metabolism. Hypothyroidism is a state of reduced thyroid hormone production, i.e. too little of the thyroid hormones. Hypothyroidism is associated with weight gain in many patients. The use of thyroxine for its treatment is associated with weight loss in about half of these patients. So in the picture here, we have a 36-year-old man with hypothyroidism before and 41 days after having a thyroxine extract. So you can see that there is a reduced swelling and reduced around the eye swelling. And this gentleman lost 5 kilograms, that is 11 pounds in weight, and his metabolic rate increased after the use of thyroxine. So this was a case that was presented back in 1940 at the conference of what was to become the American Thyroid Association. In patients already established on thyroxine, their dose of thyroxine is directly proportional to their body weight, and this is mainly mediated by the lean body mass as opposed to the fat mass. Hyperthyroidism is a state of increased thyroid hormone production, i.e. too much of the thyroid hormones. It can cause various symptoms, but in relation to today's webinar, it can cause weight loss, and this is often in spite of an increase in the appetite. Based on our own data, 73% of patients with hyperthyroidism complained of weight loss when they first presented with this condition. Hyperthyroidism is treated with either antithyroid drugs, radioactive iodine, or surgery. And we aim to establish a euthyroid state, i.e. make the thyroid hormones go normal. So once we achieve that, we call it a success. We tap ourselves and our patients at the back, and that's the end of the story. Or is it? So sometimes we have some ongoing issues with thyroid dysfunction, even in patients who are on thyroxine replacement therapy. Some patients have concerns regarding thyroid eye disease because this is a problem in parallel to the thyroid problem and can persist even when we establish the euthyroid state. Some patients have a fear of disease recurrence, and more relevant to today's webinar, some patients have adiposity concerns. They're either worried about weight gain or difficulty with weight loss. Based on the medical literature, there is some evidence of increased cardiovascular risk in the long term, and it's unclear to what extent this is mediated by the increased body weight. And another issue in the medical literature is that there appears to be a reduced quality of life in this patient group in the long term. Over the past about 2 decades, there's been some sporadic reports of a weight overshoot following the treatment of hyperthyroidism. That is, the weight that is gained following the treatment appears to be more than the weight loss that happens due to the disease process itself. So in July 19, we produced this review article where we collated the evidence on this topic, and our article was titled Weight Gain Following the Treatment of Hyperthyroidism. A few months later, this large observational study came from the Professor Bollard's group in Birmingham, titled Patients Treated for Hyperthyroidism Are at an Increased Risk of Becoming Obese. And just about 2 months ago, we produced this observational study based on our own population and in collaboration with some colleagues in the UK and Poland as well, titled Body Weight Change Trajectories Following the Treatment of Hyperthyroidism. So based on our own data on 103 patients with 344 sets of observations, and with some smart statistical modeling, we predicted that at 12 months, there's on average unexpected 7 kilograms weight gain following the treatment of hyperthyroidism. This is 1 stone and 1 pound. And at 48 months, 11 kilograms, that is 1 stone and 10 pounds. From the Birmingham paper that I mentioned before, they showed that there is an increase in body weight at 10% compared to the presentation weight, and there appears to be some plateauing effect at 24 months onwards. Again, based on our own data, there appears to be a reversal of the two lines or curves. So a reversal of the relationship between the normal weight curve and the overweight plus obesity curve. So by the end of the follow-up of this patient group, the frequency or the prevalence, if you like, of overweight plus obesity was at 70%, which is much higher than the 40% expected for our local population. And we've shown that the larger the weight loss due to the disease process itself, the more the weight gain that is expected due to the treatment or following the treatment. And this effect appears to be more pronounced with the passage of time. We would like our patients and our colleagues to think beyond weight. So whenever there is weight gain, it is important to think of which body compartments are affected, whether it's fat mass or lean mass. And you can see that we have various methods of visualizing the different body compartments. Here you have some fancy MRI technology where you can see the subcutaneous and visceral adipose tissue and the various muscle groups. And beyond weight, we need to think of the other metabolic risk factors, the other risk factors that will increase the risk of cardiovascular disease, such as high blood pressure, high cholesterol, smoking, diabetes, and so on and so forth. Another parameter that is of paramount importance is the quality of life. And in the context of hyperthyroidism, there appears to be reduced quality of life irrespective of the treatment modality that was received, as you can see from this Swedish study from 2019. Whereas in the context of hypothyroidism, there is evidence that the quality of life relates to their body mass index or their body weight. And from this same paper, I got their conclusion, which read, a decreased quality of life in hypothyroid patients on thyroxine treatment is related to a higher body weight. Weight gain needs more attention in the treatment of hypothyroidism. And the only thing I would change here is the word hypothyroidism. And I would erase that and switch it to thyroid diseases. So in my opinion, weight gain needs more attention in the treatment of all thyroid diseases. And the good news is that there are various different actions that you can take in order to make things better. I hope this served as a sufficient introduction to the webinar, and please feel free to ask any questions. Stop share.
Thank you very much, Angela. That was a great introduction to the issues. I'll pass you on now to Jonathan Hayes, who's going to share his screen and talk about it from a dietitian's point of view. Thank you. Hi, Jonathan.
Hi, Julia. Good evening, everybody. Hopefully you can see these slides on the screen. So my name is Jonathan. I'm one of the dietitians based in the weight management service up in Lothian in Edinburgh. So as mentioned in the previous webinar, we've talked around sort of weight management itself and how to help with weight loss. But Today, I just kind of wanted to go over what sort of methods of support there actually is, because we can talk about how to lose weight, but you're going to need support at some point, hopefully, or some people might do it on their own. So just this little graphic here, there's lots of options when it comes to weight loss. You've got diets, you've got medication, which is now, like I think Julie has mentioned, there's more coming out around about these injectables, which I'll talk about. Medication, and surgery. So the support that you will get will differ across the country. I appreciate that there could be people there may be some international people here tonight, but generally I'll be referring to sort of England and Wales and then Scotland, and they will differ within each trust. So it's about trying to find what support you have available to you. And like the tools that are out there to help you with support around weight loss, it's about finding the right tool that will work for you. As an example, I just think at the moment, one of the diets that seems to be, we're finding a lot of people are trying or wanting to a trend is the ketogenic diet. So in simple terms, that's very low carbohydrate, quite high fat, quite high protein. So if you think about those foods, especially given the cost of living crisis at the moment, higher fat foods, higher protein foods can be more expensive. If you think about carbohydrates, they're relatively cheap. Yes, I know, I appreciate some of them have gone up in price, but they form like quite a key staple of our Western diet, and they're quite cheap. So that's an important thing to consider if you want to embark on a diet like that, for example, and then think about the sustainability long term. Because if you go back to what you're doing before, more than likely you'll see the weight come back on. So what I'll do then, this slide has a lot of information on it. It's got a lot of jargon, but I'll just go through because I think it's important to go through or mention some of the jargon or the terms that you might hear, because they probably will be used, and it's so you can differentiate between the different ones and know which support there is out there for you. So if we start at the top, you've got tier 1. So that's general advice that you might get from the practice nurse, or you might get from, like, say, your 10-minute appointment with your GP, and they can just give general advice around weight loss. They may give you some leaflets, they may signpost you to stuff. Some GPs might be able to refer you to exercise on referral schemes. It really depends on what is available in your area. So it's worth asking your GP when you're around, or checking out the leaflets when you're in the waiting room. If you search on NHS Choices, they do have like a 12-week weight loss plan, which talks about weight loss and physical activity, and it's free. And there are workbooks or parts of it that you can download and use to work on. And that was done in association with the British Dietetic Association. So you've maybe tried that, or you've gone to GP, you want more support. Next comes sort of tier 2. So on the whole, I believe the differences mainly between England and Scotland is that in England and Wales, they're delivered by the local authority, so usually by the council. So they might be delivered mainly in leisure centres with health coaches. And sometimes there might be, you can either refer yourselves directly to them, so like a self-referral, or it might go via the GP. For instance, in Edinburgh, in Lothian, well, across Lothian, the referrals will come to us and we triage them, and we pass the details on to the local authorities which conduct the programs on our behalf, and we train them. Also there, you might find, like I mentioned to you, when you get exercises on a referral, some areas might provide with GPs on prescription, like to say something like Slimming World or Weight Watchers, or you might hear the term refer out. So with some NHS trusts, what they're doing to increase capacity, they are purchasing some places with private providers like Second Nature or Aviva, and the patient can then access these. So it's giving you more choice as well. In terms of criteria, because it's something that you will hear quite a lot of when trying to access services like this. Generally, it is a BMI of 27 and above for a tier 2 service with minimal comorbidities. So you've got minimal health conditions, you're generally fine. If you are of, say, an Asian ethnicity, it's generally 25 and above because of the increased risks associated with that, say, for type 2 diabetes. Then moving on to tier 3. So, for example, that's where you tend to find your more specialist services. Now, not every area will have a tier 3 service. The tier 3 service generally is also the point of access if you want to be considered for things like weight loss surgery or bariatric surgery, as it's called. So, for example, a good model of practice is a multidisciplinary team that involves a dietitian, a clinical psychologist or a health psychologist, exercise specialist, potentially a physio. So it's looking at the whole picture. Generally, it's then for people with a BMI of, say, 35 and above with a comorbidity. So a comorbidity might be something like type 2 diabetes. It might be a thyroid condition. It really depends on the criteria that the services have, or generally a BMI of 40 and above without any comorbidities. Now, these are linked also to guidelines, and generally, on the whole, I think a lot of bariatric services will have the same sort of guidelines in terms of access using the BMI criteria. So if you think about tier 3, maybe looking at itself, you might be less physically mobile, you might have more complex health needs and struggling to lose weight. The education is then all the focus on overcoming barriers and achieving healthy lifestyle changes to improve quality of life. So you might lose some weight, you might not get down to the weight you would like to, but if it can improve your quality of life and improve your health, that is one of the key goals. As I mentioned, this is the pathway that people may wish to go on to proceed to bariatric surgery. There's usually an element of attending so many education-based sessions, maybe losing a target weight before then your referral is sent on to the bariatric service. So the hot topic at the moment, and you'll probably see, maybe you've heard about it already, and I'm not going to go into too much detail about them, but the GLP-1s. So on a simple level, they delay emptying of the stomachs, the gastric emptying, and they decrease hunger. So the examples of them, and I've got their brand names next to them as well. So liraglutide is the drug, Saxender is the brand name. Then you've got the semaglutides, so Wegovy, which Julia mentioned, and Ozempic. And then there's the trizepatide Mounjaro. So these all have to be approved, say, for example, in England and Wales by NICE, and then in Scotland by the SMC. So at the moment, I believe across England, Wales, and Scotland, Saxenda has been approved, and I think Wegovy has recently been approved for use for weight loss in England and Wales. It'll probably be only a matter of time before it's available in Scotland, and I believe at some point there's probably potentially going to be Mounjaro as well. There are many pros and cons to these. I think, like with any medications, there are going to be side effects. I'm not a doctor, so I can't really go into too much of how the medical interactions with them. It's always worth checking with your GP about that. Common side effects that we've heard about are nausea and then decreased hunger to the point that people are having to remind themselves to actually eat something. These medications will work for some people, they won't work for everyone. And I think that ties in quite nicely with the toolbox at the beginning. It's about finding the thing that will work for you. Criteria for these, I believe I've looked up England and Wales, is quite different to Scotland. What I can find in England and Wales is that the criteria to access the injectables is pretty much based around BMIs and comorbidities, quite similar to what I mentioned for the tier 3 access. In Scotland, you have to have, it's across the whole of Scotland, you have to have an HbA1c, which is your measure of good blood glucose control, within the pre-diabetes range, and have a cardiovascular risk assessed by either a blood pressure of above 140 systolic or to have a cholesterol, I think greater than 5. But you have to have 2 of those. So you have to have the CVD or the hypertension and the HbA1c. So there'll be many pros and cons to these. There may be potentially some contraindications to taking them if you're on other medications. I believe there's no contraindications associated with thyroid conditions or medication, but I think Jonathan might cover more of that. They are available privately. I believe Saxender is available privately from a couple of well-known pharmacy brands. the last time I looked, I believed it was about £200 to £300 a month. So that's also something to consider if you want to access it privately. We've talked about this, I think, with weight loss before, but if you've got something like disordered eating, it's not advisable, or an eating disorder, to take these medications. I have come across patients with them, and it does not stop that coping mechanism in relation to food. And then lastly, the last level of support, I guess, really is bariatric surgery. So the main ones offered on the NHS are the gastric sleeve and the gastric bypass. Again, I believe Jonathan is going to go into a little bit more detail around those. We're seeing a lot around at the moment, starting to see an increase in some people going for private surgery because of the waiting lists as the knock-on effect with COVID. And I think increasingly NHS trusts are saying to patients, well, if you're going to go privately, be prepared to pay for an aftercare package as well, because unless there's any emergency complications, we can't help you if that's your decision to go privately. So that's just one, that's again another thing to think about. But generally, bariatric surgery on the NHS, you do get a lot of support pre and then post surgery. So hopefully that's explained all the options for you in terms of where to find out. As mentioned, GP surgery is probably a good place to ask if you're seeing another health professional, or the internet. If you've got access to the internet, Google is often a good place to start to find where you can access to. I believed, because the British Thyroid Foundation is based in Harrogate, I just typed in weight loss support Harrogate, and it came up with the tier 2 provider from the council, and it came up with the tier 3 options in relation to the NHS service, just like we've gone through today. And it mentioned that with bariatric surgery, you would go through the tier 3 service. So hopefully that's given you an idea today of where you can actually access the support. And if you've any questions, pop them in the chat and we'll cover them at the end. Thank you.
Great stuff. Thanks, everybody. Hopefully you can hear me. I'll just share my screen. Okay, so hello, everybody. My name's John Hazelhurst. I'm an endocrinology consultant in Birmingham. I hope you can see and hear me. A lot of what I do is kind of obesity medicine, as well as general endocrinology. I do have a few conflicts of interest that are relevant here. A drug company that's made an announcement today about a medication I'm going to mention. I also hold relevant grant funding as well from NIHR that's relevant to this kind of area, but I haven't received any kind of money or anything like that for doing this talk, and all the opinions you're about to hear are on my own. So yeah, you've already heard that access to treatment across the UK is extremely limited, and that's certainly true. About 40% of the country doesn't have a tier 2. The situation with tier 3 is less well known, but is probably similar, if not worse. And of those eligible for bariatric surgery within England, that's about 4 million people. 0.002% of patients who are eligible have surgery annually. So, you know, really that tells you that access to treatment is really very, very limited indeed. No one goes to work to deliver a bad service, and certainly I don't. And we, you know, like everyone in obesity and weight management, we work extremely hard to provide a good, equitable service for our patients. But, you know, my own service currently is receiving 200 referrals a week, you know, which we're not able to keep pace with. So there are often very long delays to enter any NHS services. There may be some of my patients on this call that will have appreciated and accepted very frustrating delays in our own service. So, but it kind of setting the scene from a kind of dietary perspective, people are always keen to know, you know, which diet is right, you know, which diet should I be pursuing? And the evidence base is, you know, is weak, actually. The answer is we don't really know. You know, the right diet for someone is one that they can tolerate, that they can afford, you know, that works, that's sustainable, etc. But, you know, there's nowhere near enough kind of information or guidance around personalized nutrition or something that might be right for somebody with hypothyroidism versus somebody treated for hyperthyroidism to recommend, diet X versus kind of diet Y. So, whatever dietary strategy you pursue, it's really important that what you're doing is nutritionally complete. And this is kind of interesting data looking at a range of different dietary interventions. And the dark kind of bars are the weight loss after the end of the diet period. You can see quite a lot of weight loss. And then the light shady patch is at the end of the follow-up. And what it really shows is actually there's always weight regain to an extent. And that's true really for any weight loss intervention, including bariatric surgery to an extent. There's a point of maximal weight loss, and then there's a period of gradual weight regain. And really what treatment you have just shifts that graph essentially. And weight regain is about biology. It's not about willpower or anything like that. This is just biology in action. So as you lose weight, things happen. Your resting energy expenditure will fall. Your hunger hormone, for example, ghrelin, will rise. Some of your satiety hormones, GLP-1, for example, will fall. This is a metabolic adaptation to weight loss because your body is essentially trying to return itself to the state it was in before. Now, that's not to say diet's not important. It's hugely important. And, it's really important alongside other treatments as well, where they are appropriate, and they are not always appropriate. And many of us, to an extent, myself included, will be following one diet or other at one particular type of, point in their lives, because weight is about weight management. So most people refer to weight management services rather than weight loss. Patients will experience periods of lower body weight and then experience periods of weight regain. And those kind of timescales often repeat over many years. Interesting. So the medication that you briefly just heard that was formally launched today is not this medicine. This is a medication called Saxenda, which I'm going to focus on, and I'll tell you for why. This is a medicine that many services across the UK have in the here and now. So Saxender is a daily weight loss injection, and the kind of nice eligibility criteria on the screen. Now, I've already told you that, best part of half of the UK doesn't have a specialist weight management service. And if I told you that this drug has to be used in a specialist weight management service, and if I told you that of the services that exist, more than half aren't able to use this drug, you'll see that access to this medication is extremely poor indeed. We do use it in my service. We are a big service that uses second most of this in the UK, but we serve a very clearly defined patient catchment, as most NHS services do. So very limited offering in terms of some of these weight loss drugs. The medication you might have heard about in the press today is a related medication, but a weekly injection called Wegovy. The issue with Wegovy, although the NICE has approved it today, it's not likely to be available in the NHS for quite some time, and there will be some restrictions on its use that will extend beyond what you'd have read about in the popular press today. And there may be some services that are not in a position to use it. These are very expensive medications. They do use them in my own service, but unfortunately they are not widely available. In terms of Saxenda, which is liraglutide 3 milligrams, the weight loss is pretty good, and in the most relevant study the average weight loss is about 8%, that kind of number. The difficulty with all of these medicines is the treatment response varies enormously. There will be, so for example in Saxenda, 40% of patients do not respond. Okay, so it's not their fault. It's not about blame. They are just a biological non-responder to this weight loss drug. It's slightly lower with the new drug Wegovy. In fact, it's quite considerably lower, but there will always be a proportion of patients who are a high proportion that can't access these medications, a high proportion that for whatever reason aren't eligible, and a high proportion that do not lose weight on these medications. So, they are not the holy grail. They are not magic. They are another tool that our patient group can sometimes work with. In terms of kind of thyroid specifically and thinking about Saxenda, we can't use Saxenda in anybody who has either a personal or family history of medullary thyroid carcinoma. And the reason is in some of the rodent literature, experimental animal studies, it certainly is associated with C-cell hyperplasia and tumors within medullary calcitonin secreting cells. There haven't been reported cases, thank goodness, in human beings. in many years of use of liraglutide at the lower diabetes dose. But what happens over time at the higher weight management dose? The answer is we don't know. So as a result, we don't use it in patients with MEN2 because they're at risk, or family history of MEN2, because they're at risk of this very rare type of medullary thyroid carcinoma. I also don't use it in another multiple endocrine neoplasia type 1 as well, because there is a potential pancreas type warning signal. Other types of thyroid cancer are potentially okay. I do use it and have used it in patients who've been treated with curative intent treatment for papillary thyroid carcinoma. However, GLP-1 receptors are expressed on papillary thyroid tumors. So I would certainly only use it in somebody who has had, effective curative treatment, many years ago, and after a kind of careful, considered conversation. You can certainly use it in patients with hypothyroidism, but I would always ensure that someone is stable on medication first, because otherwise, you won't know what's causing what. There's no documented interaction with levothyroxine, liothyronine, carbimazole, PTU, et cetera, et cetera. But availability is clearly the big problem. Bariatric surgery can be a really effective weight loss tool. Eligibility criteria are even stricter. Most places will have on the NHS eligibility of BMI of 50, or often BMI of 35 with type 2 diabetes. But the weight loss can be sustained and can be for many, many years. Here, the graph on the bottom is 20 years. But you will see in all these interventions, although the weight comes down, it does go up to an extent. And expectation management with any intervention for weight is so important. Many of my patients that lose, they might lose, let's say, 25% following a Roux-en-Y gastric bypass. When 4 years on, they've regained 10% of that lost weight. They're often very disappointed. And, I have to kind of re-express that that's a really good surgical outcome. Now, in terms of kind of thyroid and bariatric surgery, there's been quite a lot written on the effect on levothyroxine doses, but actually some of that data is not clear and not consistent. It's certainly very important that patients have increased frequency of thyroid function monitoring, even if they've been stable for many years following bariatric surgery, because it's very likely that their doses will change. I certainly wouldn't want anyone to have bariatric surgery who was being actively treated for hyperthyroidism, whatever the cause, until they had been, adequately treated. It is effective. There's great long-term data, very important reductions in mortality, cardiovascular risk, quality of life data as well. There's lots of different operations. The big two, as you've just heard, are Roux-en-Y gastric bypass and sleeve in an NHS setting. Bands are done very rarely. The eligibility criteria do limit availability. There are complications. Again, sadly, this is not a tool for everybody, and it is a tool to work with. It's by no means a kind of, a magic treatment in the same way that drugs and diet aren't either. But, it can be a useful intervention for some. So, I guess if I summarize the kind of things I've talked about, there isn't one diet that fits all. There isn't a diet that the evidence base would allow me to stand here or sit here as I am and say, if you have hypothyroidism, the diet you should follow is X. Let's say cost was an option. That data does not exist, sadly. Many difference, but please make sure it's kind of nutritionally complete. Drugs are sometimes effective, but their availability, particularly in an NHS setting, is very limited. You heard that there are private providers of stuff like Saxenda. I don't do any private work. A pen of Saxender is about £48 on a private prescription, and it only lasts 6 days. So clearly that's hugely expensive. And Ozempic, as the 1 milligram semaglutide dose, is available. That's a diabetes drug. And the Wegovy that you've heard about in the press today, and I've touched upon, isn't actually even launched in the UK, even though it's on all of the newspapers, all of the internet news providers, etc. Yes, there is a nice approval, but actually the drug is not commercially available within the United Kingdom. So a lot of this is going to take quite some time to deliver. So hopefully I've told you a bit about what there is, but in a kind of very realistic, quite pragmatic type setting. I think we're now going to lead on to a Q&A.
Thank you very much to all our speakers. Really interesting roundup of all the issues. We've got lots of questions that have come in, and please do send more in as well. I'll pick some of them. Some of the questions have been answered already, so I won't deal with them just yet. But we'll try to pick out the ones that came up. Somebody was saying, lady has had radioactive iodine twice in the last 12 months. I'm really now concerned about weight increasing again. You've covered obviously lots of steps along the way, but what would you say, particularly for an individual patient? What was her? She sounds like she's lost 8 stone. Probably that was part of the hyperthyroid symptoms. And obviously, we hear this a lot. People really terrified about treatment because they're really fearful of that weight gain, which has such an impact on their lives. What would you suggest for a patient in that situation that they do? Angelos, would you like to answer that one, please?
Yes, so this is a lady who received radioactive iodine treatment and has gained weight, correct? So
she lost weight and she's fearful of regaining the weight. She had to have radioactive iodine twice, initially lost a lot, but she's really fearful of, now she's had the treatment, it all regaining again.
So I assume that the weight loss happened when she was in a hyperthyroid state.
I think so, yeah.
So the issue here is, I know at least empirically some patients, they like the fact that there is some weight loss coming with the overactive thyroid state. But the problem here is this weight loss is to a large extent a lean body mass weight loss. So it's weight loss coming from bones and muscles and so on. So there is, like, if you are overactive in terms of the thyroid and there is associated weight loss, and then you certainly need to receive treatment to improve your overall state and reduce your risk of various complications. With that treatment, you may get some weight gain. And to some extent, this is to be expected because we want to build up the bone that was lost because of the disease, or the muscle that was lost and caused you some tiredness and weakness. But I guess the question is, what can somebody do in order to avoid excessive weight gain? And I don't think there is there's no study that specifically answers this question, but from our clinical experience and using common sense, the chances are that whatever principles are applied in high weight or weight gain in the general population can be applied for patients with thyroid diseases as well. So we would follow the usual steps in order to limit weight gain. That is lifestyle advice, following various dietary principles. If need be, see a dietitian. Exercise is very important. And then in a minority of cases, there may need to be, we may need to give pharmacological treatment, these newer medications that we heard today, provided that they fulfill certain indications and criteria. And in a smaller percentage, weight loss surgery may be an option in the long run. And of course, after a euthyroid state, a normal thyroid function state is achieved. I hope this answers your question.
You're on mute, Julia.
Apologies. Jonathan is at Hazelhurst. There's a question here specifically about Saxender. Why why treatments like this only available through endocrinology, or sorry, through specialist clinics? Why can't GPs treat patients with them? And surely that's one of the reasons why there's such a backlog in patient, or wait for patients to get hold of it.
So Saxenda, part of the kind of NICE agreement is that they have to be delivered through a specialist weight management service, and they also have to be delivered within a commercial agreement between the service and the provider of the medication. Yeah. So there's a lot of restrictions that have kind of built into that. You know, in very simple terms, a lot of this comes down to cost, actually. My hope is that access to weight loss medications will normalize over time. You know, we've gone from having historical dangerous medications, which either didn't work or associated with marked side effects, to now having, you know, one new medicine approved in 2020, another one approved today. You know, we're at the kind of beginning of effective, safe weight loss pharmacotherapy, you know, and like a lot of these things, it will take time to normalize that. So clearly weight management treatment, sadly, and the way it's commissioned is heavily affected by stigma in a way that, you know, something like type 2 diabetes treatment, you know, isn't. So I think we will see big changes in the near future. So this new drug has to be delivered by a specialist weight management service, but it doesn't have the caveat that it has to be delivered by a tier 3. So it's going to become more widely available eventually. We're also hoping that after it's initiated by a weight management service, that in many areas of the country, GPs will take on some of the subsequent prescribing responsibility. That's its likely direction of travel. So, you know, these are frustrating times for patients. They're actually enormously frustrating times for people that work within the service as well, because we would like to provide these effective treatments to more people in a more equitable way. You know, we're big users, but, you know, we have a catchment area that, you know, if I didn't stick to my catchment area, I couldn't provide the service that we do, that is under enormous pressure, because we'd be seeing people from everywhere else. So, you know, in areas that services don't exist, you know, I would strongly recommend people to, you know, consider, you know, communicating with local politicians, you know, local stakeholders, integrated care boards, etc., to say, you know, why don't we have a weight management service? Because actually there is a lot of inequity in the system.
Thank you. Maybe we should all be writing to our politicians locally to put pressure on them. Maybe that might make a difference. Jonathan Hayes, this is a question for you, I think. And you talk about this in the weight loss program, about how to set realistic goals for ourselves and the importance of that. There's somebody here who said they had Graves and a total thyroidectomy. They lost 12 kilograms. BMI is now 29, but there's a temptation always to compare yourself with other people at the gym, and you see losing weight with other diets, but it seems to be harder for thyroid patients. How do you avoid feeling despondent when you compare yourselves with other people and set goals that are personal to you, that are more realistic to follow?
Interesting question. So I think it's very easy in today's culture to compare ourselves to people around us, to think, well, for example, I hear it often a lot in weight management example, take a couple. One person, they both might be doing exactly the same diet, and you'll often hear, well, one's losing about 4 kilos a week and the one's only losing 1 kilo a week. We're all different. So I would try to avoid comparison, focus on your goals, focus on what you want to achieve and how it's going to improve your quality of life. And it might just be that you get there a little bit, it takes you just that little bit longer to get there. You know, there are many things that, you know, when we compare people as well, we only see that snapshot in time. So some people might, for example, they say, oh, I don't know how she manages to stay so thin. All she ever does is eat so much. But that snapshot in time, when you might see that colleague or friend eating at lunchtime, you don't see them outside of that window. So you don't see them from when they wake up. to that lunchtime, and then afterwards when they've left you and when they go home. So you don't know what they do in between those times unless they explicitly tell you. So it's very easy to compare in the moment, and especially what you see. So we're in the gym. Yeah, I don't want to comment necessarily on habits of gym users and what supplements or legal or illegal people may take in terms of the sporting scenario to help with weight, for example. So, but yeah, try and focus on yourself. It's very easy to compare, and especially when the social media is out there as well, it's very easy to. I just wanted to add, if that's all right, Jonathan Hazelhurst. So, you're talking about Saxender in answer to that question. Correct me if I'm wrong. I think with the NICE guidelines, as I'm more familiar with the Scottish ones, I think it's only going to be for a time-limited period. Is that right? There was around 2 years.
2 years.
Yeah. So I think
Saxender and Wegovy 2 years.
Yeah. So I think, if it suppresses the appetite, but the injections don't actually change the behavior. And I think that's also why there's that part of it about wanting people to be engaging with a specialist weight management service, whether that's tier 3 or something else, because if you have poor dietary behaviors before, then you take the injections and they stop you from eating, so you lose weight, but then you just go back to them. Then that's 2 years of injectables that haven't really ended up giving you much benefit if you then regain all that weight.
Thank you very much. That's sensible advice. And if anybody hasn't looked at the videos, Jonathan's articles on our project, he gives lots of really sensible ideas about setting goals and how to do that. And there's a couple of 2 or 3 questions here about thyroid treatment. Angelos, I don't know whether you'd like to deal with that. About in your work, have there been any in the research projects that you studies that you referred to, have there been any studies that compared treatments as far as weight loss is concerned with combination therapy, T4, T3 versus levothyroxine only, and what is the role of, if there is one, for liothyronine as a weight loss tool? Because many people contact us and have read that there is. So what would your comments be?
Yeah. So in my own sort of academic interest, I'm more focused on hyperthyroidism. But I'm like a general endocrinologist. I'm familiar with the literature on hypothyroidism. So the overall consensus from the studies to date is that the combination of T4 and T3 does not offer any significant benefit, any significant benefit in terms of hard outcomes like cardiovascular outcomes, but even in terms of quality of life, it's not proven to be superior. And then with the combination, with the use of T3, so one factor to take into account is that the T3 preparations that we currently have available are quite short-term, or their effect is short-term. So I think there is work on more long-acting preparations that will be more physiological. So there is some issues in terms of monitoring of these patients. It makes the monitoring of their thyroid status a bit more tricky. I'm not aware of any big benefit in terms of body weight or body composition. I think maybe some studies, I have looked at the evidence in the past, but not recently, but I think some studies may have shown some very slight benefit, which is clinically, is of debatable clinical significance. In terms of thyroid hormones in general, I mean, I think a sensible question would be why not use thyroid hormones to cause weight loss? And we know that an overactive thyroid state will cause weight loss. And I to some extent, I answered this before. So in terms of, so you have to look at the benefits and you have to look at the drawbacks of using thyroid hormones, any thyroid hormones for causing weight loss. So the the drawbacks are clear. So you can cause arrhythmias or increase the risk of cardiovascular disease, increase the risk of osteoporosis or even osteoporotic fractures especially in the older age group. But I think from previously reviewing the literature, in order to achieve weight loss with thyroid hormones, although there is not there's no big studies on this issue, my overall feeling from looking at the literature is that you have to give reasonably big doses of the thyroid hormones in order to achieve weight loss. So that's one problem. And then you have the side effects if you give big doses of these medications. And then, as I was saying at my presentation, you have to think beyond weight. So yes, if you give big doses of thyroid hormones, you may achieve some weight loss. But if you are losing lean body mass, i.e. bone and muscle, then it's not worth the hassle. But I think there is maybe some work on this in the future. If you could direct the thyroid hormones at specific places like adipose tissue, and I've seen one question about thermogenesis and brown adipose tissue, which causes thermogenesis, then that'll be great. But you somehow need to protect the other organs like the heart and the bones from the thyroid hormones. And I think there is some work on this field, but it's probably still early days.
Thank you. Thanks for picking up that question about brown adipose tissue. If anybody hasn't read Professor Marion Ludgate's article specifically about brown adipose tissue in the resources on our project website, that's a really interesting one that delves into the science of that. There's a question here, Jonathan Hazelhurst, hopefully you can answer. I've unfortunately gained 2 stone in the past year. Is my thyroxine dose now likely to need increasing? And there are a few questions around these themes, really. If you've felt that you've got significant gain or loss of weight, how come our thyroxine doses aren't being altered?
This is obviously a difficult area that is always going to prompt questions, in this webinar. If you've had a significant period of weight change, whether that be gain or loss, then I think it's important for patients, with thyroid disease to have a blood test first and foremost, and to discuss that with their clinician. It may be that, if there has been, we typically dose levothyroxine on a kind of estimated lean weight. But certainly if somebody has gained a significant amount of weight, they may well need a dose adjustment, but that would depend on, really on their blood tests and what was happening with their thyroid function. Lots of people would always talk about T4 and T3, and I know that's a really important contentious area for many patients on this webinar, and I know that there are many challenges within the NHS and, possibly beyond. And obviously some of that, relates to cost pressures as well. And, the evidence base is often discussed, and, it is difficult. And I don't really want to say too much, outside of, my own patients, etc., and my own practice. But, I would really encourage people in this webinar to not want their TSH to be suppressed. And I know that there are patients that, are on combination T4, T3 or T3 in isolation at supraphysiological dosing. And, my own view, having seen this, many, many times is, the risk actually of secondary osteoporosis and cardiovascular risk, is very real. Unfortunately, obesity and weight gain is very, very common. Within the latest kind of NHS digital report from England, the prevalence of obesity, is 29% within England. It's really important that other things are considered, other deficiencies are identified and patients are appropriately treated. But, in general, I'm really keen that patients not pursue very large doses of potentially harmful medications. There are sometimes people that, can buy supplements online, weight loss supplements. unfortunately, they sometimes still will contain, thyroid hormones from illicit providers. And, every year or so, there are cases of people, that have died who've had a kind of cardiovascular event, and actually it's become clear that they've been taking these supplements. And, I know that access to effective treatments is limited. I'm sorry, I work in this space. I've worked very hard to improve what we do and help those around me improve what they do. And I know it's frustrating for patients, but, I just really encourage everybody to think about safety first and, actually have a discussion with their own clinical provider. And I know that's a woolly answer, and it's woolly quite deliberately. So I'm sorry if that's frustrating for people on the call, but, I think it is important to state.
Thank you. And it's always a good tip as well. If your weight has changed, either you've gained or lost, it's always important to go to see your own GP to get up-to-date blood tests. There's a lot of people we hear from who haven't been able to see their GP or haven't been called to see their GP for a long time. And we always say to them, it's definitely, if you've got symptoms, it's always worth going to have a blood test at least every year to find out whether your dose needs changing. And this particularly, your needs might change as you get older. I'm just to the panelists, are there any particular questions that you would like to pick out for us to? A lot of the questions have been answered in some way in the presentations.
Can I make a quick comment?
Yes, of course.
No, just regarding the use of the GLP-1 analogs for weight loss. It's always important to remember that when you have a combination of lifestyle measures and dietetic input on top of the GLP-1s, the outcomes are better than when people just take the medications and don't focus on lifestyle measures. And when I counsel people about the pros and cons of these medications, I do mention that at the moment we're still not fully sure how long we should be giving them for. So that's a relative drawback to their use, but there is some there is a school of thought that people who use them and it gives them some motivation to do lifestyle changes and to improve on their behaviors around food and so on, are more likely to be able to come off these medications at some point in the medium term.
Thank you. There's one question I can answer, can refer you to another of our webinars. Actually, somebody's asking if there's a scope to do a webinar where we can understand blood test results better. So we have done a BTF webinar about a year or so ago, specifically about understanding thyroid function tests. So if you'd like to go to our YouTube channel, you can find, or website, you can find all our previous webinars there. There is also a debate about T4, T3 combination therapy, which might be interesting for those of you who aren't familiar with the conversations around this issue. But I know that a lot of the people on the call will be familiar with those. There is a new consensus statement that should be published in the next few weeks, I hope, with it's the British Thyroid Association and the SFE, a joint consensus statement to help with prescribing of liothyronine in the NHS. So I hope that will help with some clarity for patients and clinicians around this area, which and there are still many parts of the England and Wales, certainly I'm not sure about Scotland, where patients whose doctors would like to start them on a trial of liothyronine because they think they might benefit, can't access it, and that we all acknowledge that is not an acceptable situation at all. So I think that's probably all the questions we've had time for today, because I'm aware that you all have other things to do with your evening. We will try to summarize the questions and type them up in a transcript and make them available, and there will also be a recording of this webinar available from from tomorrow, hopefully. So if you'd like to go back and listen to it or share it with anybody else who hasn't seen it, you're welcome to do that, share the recording. Thank you enormously to our fantastic speakers. I really appreciate your expertise and the time that you've given us tonight. It'll be really helpful, and other people will go on to watch this webinar and learn about these important issues that I'm not aware of have been talked about with the patient group before. So we're really grateful to that. The two takeaways I get particularly from your talks were, one from you, Angelos, that weight gain really needs more attention in the treatment of all thyroid diseases. And I hope that the research that's going on now and will do in the future, there will be more focus on supporting thyroid patients. And from Jonathan Hayes as well, the important thing is to find out, and I think Jonathan Hazelhurst also mentioned this, it's all about finding out what works for you. There is not one size fits all. And I hope that the BTF project in some small way might help you with this, and your weight loss journey within the thyroid community might be better supported. Again, so if you would like, I'll try to share my final screen so you've got links to the relevant bits on our website. Our webinar will be available on YouTube. Any further questions you've got that we can help you with, please do get in touch. We welcome any feedback as well, of course. We make a suggested donation of £5 towards the webinar tonight. All of our services are offered for free, and to enable us to continue with these, we really do need support. And finally, those are the details. If you would like to register for the BTF weight loss project, it will be going for another few weeks. It will be open, and then at the end of 6 months, we'll collect all the data and try to establish what has helped you and what we could be doing more to help and support you. And we'll be sharing that information with medical professionals who can, in turn, hopefully will improve support for thyroid patients. So finally, a thank you to our speakers, and an enormous thank you to all of you who joined us tonight as well and asked really interesting questions. We really appreciate it, and we couldn't run these webinars without you. So please stay in touch. Look forward to seeing you at our next webinar, and have a good evening. Thank you.